So in this video, I wanted to play devil's advocate because I've been seeing a lot of posts on like social media, Reddit and stuff, particularly surrounding the controversy basically of occupational therapy moving away from the biomedical model. So those of you who are not familiar, a lot of therapies, like for example, physical therapy is like well-grounded. A lot of the education, training is based on the biomedical model. So like anatomy, physiology, all those things surrounding it for like manual therapy and just improvement in function based on this medical science, right? But a lot of occupational therapy, I wouldn't say this isn't even a recent thing. Like a lot of our roots are grounded in mental health. So I learned especially in OT school, right? We aren't just solely based on the medical model, such as the biomechanical, when it comes to like treatment and movement. We also should consider the psychosocial, right? The mental health aspects, cognition, right? One's cognitive ability in how it may be impeded or just dysfunction related to things like depression, right? You can relate it to poor memory, attention, and that can manifest in how we function. And so I actually fall somewhere in the middle when it comes to like which approach, what we should learn about. There are important aspects where we should focus on each of the models. So having a strong foundation in, already in the biomechanical, I think is a prerequisite for OT school, right? So anatomy and physio, but a lot of the complaints and stuff, criticism when it comes to OT school is like, well, we're not focusing enough. We're not doing enough training in it. We're just focusing on other things. Like I even saw on Reddit, like one like student said they learned a lot of like ceramics or something. So they don't see a lot of this real world application. How am I playing devil's advocate here? When it comes to chronic pain, I think this is a good example of how the biomechanical model fails to explain and treat chronic pain. Because, we've known about chronic pain for a long time in history, in human kind of function in our like day-to-day life. We all experience it to some degree or another. However, knowing so much about chronic pain, even down to like the cause of injury, right? Or the diagnosis may not necessarily be enough, or even like the manual treatment and the therapy and the movement is not solely enough to treat chronic pain. And a lot of people who experience chronic pain, those of you who do experience chronic pain, know that just treating with, say, like medications or physical therapy, the traditional manual physical therapy, is not necessarily enough to help treat chronic pain. So I want to point you guys to an interesting article, and this is by Louw, and he's a pretty prominent pain researcher, clinician, educator when it comes to chronic pain. And in this paper titled A Clinical Perspective, and he's a physical therapist, by the way, on a pain neuroscience education. So he's a proponent of pain neuroscience education and this approach to manual therapy, which is traditionally really biomedical, movement-based, biomechanical. So in this abstract, I think this really highlights my point of why a only biomedical model is not very strong. And this is why one of the strengths to occupational therapy is our holistic approach to engagement in meaningful occupations through the approaches such as approaching and addressing the medical as well as the mental and psychosocial aspects to one's background and their day-to-day function. It opens with, in recent years, there has been an increased interest in PNE, pain neuroscience education, and physical therapy, but I think this is also pertinent to occupational therapy. There is growing evidence for the efficacy of PNE to decrease pain, disability, fear avoidance, pain catastrophization, limited movement, and healthcare utilization in people struggling with pain. PNE teaches people in pain more about the biology and physiology of the pain experience, including processes such as, this is the neurosciences part, right? Central sensitization, peripheral sensitization, allodynia, inhibition, facilitation, neuroplasticity, and more, right? So this is all very biomedical. He goes on to say, PNE's neurobiological model often finds itself at odds with traditional biomedical models used in physical therapy. So what he's saying is that the PNE neurobiological model incorporates other things in addition to the traditional biomedical model. So traditional biomedical models therefore focusing on anatomy, pathoanatomy, and biomechanics have been shown to have limited evidence in helping people understand their pain, especially chronic pain, and may in fact even increase a person's pain experience by increasing fear avoidance and pain catastrophization. So what may contribute to one's poor pain outcomes is due to their pain catastrophization and fear avoidance. And we have known, and what we're seeing in the research is these psychological, psychosocial components of chronic pain actually can make pain outcomes when it comes to function and quality of life. We're not just measuring solely like pain, like intensities, like OPQ, onset, provokes, quality, region, severity, time. Not just only those factors, because what we're seeing with chronic pain is that even though people have improved outcomes with pain measurements, traditional pain measurements like intensity, like after surgery or managed with like medications, we're not seeing increased in function. So you OTs out there, we're not seeing improved quality of life, lower levels of disability when it comes to chronic pain. So what gives here? What's going on? Well, there's a lot of other components that aren't just the biomedical. Like those of you OTs out there, those of you OT students know that the psychosocial play so much into one's life. That's why we have like mental health, right? There's LMFTs out there, psychologists, right? Psychiatrists. There's a whole nother world out there. And when it comes to chronic pain, knowing about and treating the psychosocial with chronic pain, such as using a biopsychosocial model, is shown to be that much more effective than solely relying on the biomedical model. And I think this is the reason why our medical community, our practitioners, even though with the best of intentions in our pharmaceutical like industries and, you know, manual therapies, even though all this time we're putting so much effort, cost, training, education, therapy into this treatment of chronic pain, we have been over-reliant on a biomedical model in this movement model, this traditional model, and not looking at the newer kind of approaches, which has been here all along. It's just newer, but newer when it comes to chronic pain. And I think that's why we have failed the chronic pain community and our patients and our clients, because we haven't looked at it from a more holistic approach. And I think this is where occupational therapists, this is where we should step up and where we should kind of step up to the plate, because we know this, right? We know this kind of holistic approach when it comes to function and our client factors and addressing all of these components using whatever theory. It's not just PO, but like looking at the MOHO, right? And the Kawa model and all these other things that we know about can help improve one's function, right? Motivational interviewing, right? There's so much that goes into it. Whereas we're traditionally only looking at treating chronic pain with like medications. We shouldn't be at the mercy and like waiting for, like say in acute care, for pain meds to kick in as an occupational therapist. We have so much more in our knowledge and our toolbox when it comes to mindfulness, teaching breathing, mental imagery, motivational interviewing, right? Finding meaning in engaging in occupations and activities that are actually meaningful, that are valued occupations, to set goals that align with one's values, right? And what they're motivated by, right? And what are they fearing? Like all this negative kind of cognitive part and psychosocial part. What are their fears? Are they miseducated and not just well informed about pain? And are they just freaking out when they like hear about their pain, like scan or their diagnosis, instead of being empowered and learning about pain and knowing that movement is okay? This is all beyond the biomedical model. So this is why I think it's important. Why am I lately so passionate about chronic pain is because if you ask me what's the number one diagnosis I think every occupational therapist should be comfortable treating and knowing about, it's chronic pain. Everybody experiences pain to some degree. It's not like autism or cancer. More likely that someone's going to experience chronic pain. That's why it's one of the most debilitating kind of conditions. Why number one reason why people seek medical attention and like go to the doctor is for chronic pain. And this is where I think occupational therapists can step up and fill in the gap by implementing and using our background and our tools and our theories and our research and really what our roots are in treating chronic pain using a beyond the biomedical, using such as a biopsychosocial model. So let me know what you guys think of that. This is a really good example of how the biomedical model is just, we shouldn't be only focusing on it. And this movement away from it is actually a strength. I'm not saying to completely ignore it and like not teach it. And like, I think OT should have and should have a strong foundation in the biomedical model, but also learning about how to complement it with other things such as the PNE, pain neuroscience education, or the biopsychosocial model where we implement all these other things that we already know. So let me know what you guys think about that.